Sure
Welcome,
thing.
Simphiwe, to the channel. Can you just say a bit about your current role and what that entails?
My current role is a contraception and sexual health nurse consultant. I'm also the lead nurse for our organization, actually, so the lead contraception nurse. So what that entails is basically, I guess when you're more junior doing a sexual health role, it's more sort of testing for sexually transmitted infection, counseling women around different contraception methods. Whereas once you get, I guess, to contraception nurse consultant, then it's more teaching. So I do a lot of teaching around contraception, sexually transmitted infection, and this is more aimed at health professionals. So health professionals, so nurses, doctors, pharmacists, so it can sort of vary. And then I do another stream of my role is commissioning. So commissioning sexual and reproductive health services. So that can be, so like in pandemic, for instance, there was a lot of sexual health services that were closed, and then unfortunately we accrued a lot of waiting lists. So this entailed us sort of looking at bespoke ways to commission services quickly in a way to ensure that we reduce sort of the waiting list. So we're still doing a lot of that. And then there's the policy and governance side as well. So I think it's sort of a multifactorial role. So I love to be clinical. So that's why I still do the teaching element. I don't think I'd give that up just because I'm such a people's person. But I quite like being able to shape services as well. So the guidelines, policies, the commissioning, and the governance side as well. That's like the role in a nutshell.
Wow, there's so much in there to unpack. How do you get into being a sexual health nurse consultant? Because it's not one of those traditional job roles that you see advertised, I think, on NHS jobs.
That's true. Yeah. So I guess where I started, my journey started as a Band 5 nurse. I would say that I did a little bit of gynae, but I never put that on my CV or anything, just because I did it for less than 6 months. I've always known that for me, sort of acute care and hospital working was just not my strongest point. So I started off as a Band 5 sexual health nurse. And they take newly qualified, so you don't have to have any skills because we teach you everything. So I started as a Band 5, working in sexual health, and like I said, doing the testing, treating, managing sexually transmitted infections, and then you start to do a little bit of contraception as you're more experienced. And then obviously once you're a little bit more experienced, then you can become a Band 6, which is what I did. Became a Band 6 nurse, and then did a lot more of that and did a contraception, and then you start to support staff, support nursing students and midwifery students, and then I became a nurse practitioner, and then it's just been developing more skills. Did like PGD stuff and supporting a lot of PGD and training as a Band 7. So I think I was a Band 7 for about 6 years, and then I moved on to my Band 8 role.
Okay, so your nurse consultant role is a Band 8.
So it's equivalent. I guess it's equivalent to an 8B actually, within the NHS, just because I do education and I manage. Whereas if you do more just education, it's more of an 8A. So mine is a bit, because I'm in the private sector. I've moved out of the NHS, so we don't actually quite band it like the Agenda for Change.
Okay. That's interesting. That like you say, it's in the private sector, and you mentioned having, like, you do teaching. So I did a PG dip in teaching for healthcare professionals. Did you have to do a course like that to do the teaching, or is it part of in the role and already doing it's part of your learning on the job?
So it's been part of learning on the job and just providing that as because you're experienced in that field. There are colleagues who've done the PG dip. I haven't. I did my master's in public health. So that's sort of how I guess I managed to still do a teaching role, because you have to have an MSc element, so you don't necessarily have to have a teaching role, teaching qualification, so that's how I've managed to be in that role.
What made you decide to do your an MSc in public health?
Because a lot of my role is about the public, and how we can support the public to obviously have better health and better well-being, so it ties well into that element. And obviously I enjoy engaging with the public and enjoy supporting sexual and well-being of individuals. So I think it made sense for me to sort of have a qualification and just understand more, the determinants of health and how, health inequalities affect certain populations, just because that's quite an important area of my work, I reckon. And yeah, I think also being a Black woman, there are so many disparities that unfortunately affect Black and brown people. So I think public health just made sense for me to do that qualification.
The fact that you talked about the disparities in health, I know because you've got an Instagram channel, so Black Nurses and Midwives, which looks at things that are specific to Black communities. What made you decide to do that?
So yeah, I think pandemic is probably the main reason why I started that page. Just George Floyd, pandemic, lots of disparities, I think, that were sort of swept under the carpet, unfortunately, with COVID. They weren't really highlighting them, very openly. But I think conversations then started to occur, and which is why I opened that page. I think it's just important to educate people that look like us, and I think it's always important coming from us. I think a lot of the time there are, certain health conditions that are highlighted by, white people. I'm not saying that it can't be, but I think it's important to also have health education that comes from people that look like us, because we know how to engage with our community as well. And I don't want us to be hard to reach. We're not hard to reach.
No.
We just don't have the right people delivering this education, and I think that's important. So that's probably why I share the content that I share. It's also generic, information for everybody, but there are specific things that I might share that affect Black and brown people.
Yeah, and I do think it's important, like you say, the message is the messenger is even as important as the message. And
completely.
And it's good that you're doing that, because I've learned so much. Because you recently took part in a program with Davina McCall as well, talking about exactly stuff like that. And how did you get the call around doing that, just out of interest?
So actually, a friend of mine who I met through social media on Instagram is a producer. So she had reached out to me regarding the menopause program that they were doing, and asked if I wanted to do that. And I was like, well, I can give information around like people's experiences and me working within that setting. I can't really give personal experience around menopause. So then I sort of supported her to get somebody who could give their personal experience as a Black nurse working within the NHS and how she felt going through menopause. So then she was like, oh, well, let's do something on contraception, potentially in the future. And obviously Davina was up for it as well, and I was up for it, and that's sort of how I fell into it.
Yeah. You spoke about also the other part of your job is around policy. So how does your day-to-day, the teaching and the work on contraception then slip into the policy bit or the governance bit of your work?
So I think with the policy side, so it's just ensuring that obviously our guidelines and policies are up to date, so evidence-based. So as you know, contraception and how things change, not all the time, but there are key things, or there's new data around, let's say, a certain side effect within a certain contraception. So I just need to ensure that our policies are up to date and have that key information. So it's around that, and just policies. All of our policies are like internal policies. So as much as we have, the Faculty of Sexual and Reproductive Health that has their main guidelines, and we adapt those to fit within our setting. So I do a lot of that adaptation, not unfortunately, but that tedious job that some people might not like. And just obviously commissioners, different areas might ask for different things, and we're quite lucky that we're not affected so much about the postcode lottery and what contraceptions are available in certain areas. So that doesn't affect us so much, but there are areas where you have to work with the commissioner with certain, it depends on what's within their formulary, for instance, because there are particular methods that might not be. So sometimes when I'm teaching, there is that aspect that we have externals that I'm teaching within a certain area or teaching them about what we do. But then obviously there might be questions around what they're doing as well. And obviously it's understanding what they're able to provide. So especially with the newer contraception, so the newer pills that are slightly more expensive, but we know are quite good at managing heavy, painful periods, but are not necessarily commissioned everywhere just because they're more expensive. Just to give like context, basic pill like microgynon can be like something like £1 something for 3 months supply, whereas these newer ones can be anything between even £25 to like £45 for 3 months supply. So obviously you have to have a really good reason why you're giving that specific method, and sometimes there is that element that there is different commissionings that they might be like, no, actually we're not going to put that on our formulary.
Yeah, and I guess it's hard with and this is testing my pharmacology knowledge. So I know sometimes when new medication comes out, whichever pharmaceutical's making it might have a monopoly on it for a little while. Is that why the cost sometimes is that high until you can have a more generic version of it? So, okay.
Sure. So when it first comes out and that's the only one available, and then as time goes, so like microgynon, it's got so many sub names because it's the one that was founded, the first one. It's been around for many years, and there's been new pharmaceutical companies who've changed it and changed the brand. So there's different brands, and obviously the more brands there are, it kind of dilutes it down in terms of pricing. So there is that element, definitely, certainly.
And you mentioned about commissioning. So is it that you've got to? So when I worked in a previous role, because I work in the NHS, the service I had, we had to do a monthly report to commissioners with key performance indicators and stuff. Is that your role, or do you sort of help them the other side? Are you on the other side looking at what people are doing and then buying services? Is it
so I'm more on service provision rather than the reporting. So we've got somebody who does the reporting. Obviously they might ask me key things around sort of what does this mean, or just give a bit more context, and I do attend the meetings, but I'm more on the service delivery side. So have we met? So for instance, they might have said, oh, we've got this waiting list, we can give you this, so what are you able to do within like what time frame? So I'm more on that side of the sort of what we can do. So there's a lot of innovation that has to come with sort of that side of stuff, just because sometimes we don't they don't necessarily have staff, but they might have facilities to give you. So then we might need to provide the staff and facilitate that particular service, and obviously we're always accountable to them because it's their money and their patients, essentially. So it's slightly different than the day-to-day reporting and stuff like that. I mean, I do a little bit of it, but I wouldn't say that's mainly what I'm doing within it.
In terms of some of the challenges of your role, I'll go at challenges and then you can talk about the best bits. Are there any sort of challenges being a sexual health nurse consultant?
Challenges. I feel like there's always, challenges with any role. I guess for me, I think I'm such a I think challenges, I always see a positive kind of light on how can we make this challenge. It's a bit like managing staff. People might say, oh, it's challenging. Yes, it's challenging, especially if you've got a staff, let's say, who's always late or blah, blah, blah. But I always try and work with people. There's reasons why people do certain things, and I think I'm more of a manager who tries to understand what's going on within that person so that we can work together, because I think it's so important. Life is hard. I think it's important to really support people, and I think being a woman myself, a young woman, I'm all about supporting sort of people I work with. So I'd say that yes, that's probably a challenge, but like anything, I think if you see it as a challenge, it's challenging. Whereas if you see it as a positive, like how can we work and change this, then it can be more of a positive thing. I guess possibly other things is like anything, commissioning, can be a bit tricky, especially when they want you to deliver things in a certain time and you're like, we can't fulfill that. So maybe time frames that are sometimes stipulated within a commissioning time frame, that's probably challenging. yeah, that's probably the hardest. Or maybe incidences, managing incidences. So maybe if a patient's had a bad experience, and they've sort of written a report about a particular staff member, so probably having to have those challenging conversations about trying to understand what's gone on, and just trying to unpick all of that is probably what's more challenging actually.
Okay, and some of the positives of your work.
So the positives is I get to do really cool things. So like you said, being on the documentary, even though that didn't come via my job per se, but it's nice that I got to be on a documentary talking about things I love talking about, which is women's health, contraception. I get to meet lots of cool professionals. I get to go to really cool conferences, and I just shaping the future of women's health for me is probably the highlight, and also supporting other Black professionals, to also gain their skills and develop, and knowing that actually, yes, you can work in the NHS, but you can work in the private sector. So I worked in the NHS for a while, but also, supporting Black and brown professionals that actually can move away from the NHS, and it's absolutely fine, because I think people are sometimes afraid to do that. But also Black and brown professionals within my organisation, I'm always happy to support them and develop them as well.
And I'm glad you said that, because it leads me to, there's two things that I want to ask. Is in terms of, so in the NHS, or I guess across the country, there's lots of work around anti-racism, and there's lots of schools of thought on that, in terms of how do you get equity for people, whether that's supporting their development in their career, or ensuring that people have got the same access to healthcare, no matter what postcode they're in, what colour their skin, etc. What sort of things do you see happening in the, I guess you work in the private sector, to sort of meet those bigger agendas?
So I think it's hard, because actually in the private sector it's predominantly white. There is a lack of diversity for sure. Within my organisation, I am part of the diversity inclusion. So we are reviewing. So we review our workforce to see whether it is more, as we know, it's more Black staff that are more junior, and then as you are more senior, it gets whiter. So we review our sort of recruitment to ensure that obviously it's diverse. We also provide support, like one-to-one support, if staff are feeling that they're not being adequately supported or being discriminated against. We do a lot of training, as other trusts do, around supporting Black and brown people as well. I think it's hard, because as much as there's a lot of things that are happening, I think we're not always very good at ensuring that I think sometimes we think that all Black people think the same, or one thing that we've implemented fulfills all Black and brown people. But I think we need to also be a bit more individualized, like think about people as individuals, and support Black and brown people, regardless that they're Black, just seeing people as individuals basically. I think is so important.
If somebody wanted to get into your role, how would they do that, or look for jobs in the private sector where it is?
Well, I would say that NHS jobs, that's the easiest way you can get sort of jobs, because we advertise on there as well. I'd say sexual and reproductive health jobs, it's always good to, I wouldn't say start in the NHS, but I'd say starting in the NHS is very good, because you grasp the sort of basics, and in terms of learning. Private works very differently, and obviously you've got certain things that you need to fulfill, whereas I think with the NHS you don't have those other external pressures. So I think it's always important to start in the NHS within sexual health, and just learning the basics there, and then moving on. Like anything, you definitely can start private. I know people who've gone straight to private and have worked there and haven't found any challenges within working that setting. But you can find jobs on NHS Jobs, LinkedIn, Total Jobs are sort of ones that you can find jobs on as well.
Brilliant, thank you. And where can people find you, just to see the brilliant work that you're doing and follow you?
So you can find me on Instagram and TikTok as Black Nurses and Midwives UK, and you can find me on LinkedIn as Simphiwe Sesane as well. And yeah, that's
fantastic. Thank you so much, Simphiwe, for your time today. It was really, really good.